And I would like to first thank the Dean, the Vice Chancellor, Dean, and Dr. Tamar Sharma for inviting me to this great conference. And nice to see all my other colleagues, Prof. Tilak, Dr. Ranga, Dr. Anand, who I see in Malaysia. So what I'm going to do is probably something that many of you have heard before. And it's just that now I'm just trying to update after our workshop, which was like way back in 2013. Okay, so for those who have listened, you may see similar things. So first of all, we're going to talk about definitive diagnosis of verrucopapillary lesions, which really relies upon identification of microscopically evident architecture and cytological characteristics of exophytic papillary features. So if you look at this little diagram, we can talk about verrucopapillary lesions as in looking at the number, looking at the appearance, and whether they are focal or multifocal, and whether it is something that's HPV involved, and whether they are of etiologically reactive or infections or idiopathic or neoplasm, and whether they have a malignant potential. So whether it's benign, potentially malignant, or malignant. So that's basically a whole series of verrucopapillary lesions. But today, I'm just going to talk about those with malignant potential and the ones with malignant behavior. And this is something that I have shown you way back in 2013, and I think I've shown again in 2016. So this is a lecture that I gave in at the 18th IAOP and IAOMP conference in 2016. And now I've had different thoughts. So I'm presenting this overview, this diagram again, but with all the new the development and the differences in thinking, and also with more papers that has been on these lesions, I've come up with something like the first part, the benign, is still the same, but the lesion in OPMD, we talk about verrucous hyperplasia, and we all know that it can be in proliferative verrucous leukoplakia or in oral submucous fibrosis. However, it is still debatable as an OPMD if it is a verrucous hyperplasia by itself. So I think the history is that when we started in 2013, we tried to say this is potentially malignant disorder. But I think a lot of pathologists do not agree to this, except for the fact that it is within proliferative verrucous leukoplakia and oral submucous fibrosis, which is an OPMD. So in order to say this is a potential malignant lesion or not, we really need a lot more studies. So the basis of this, of what I'm doing since 2013 is to come up with criteria so that we have a collection of materials to show us whether it is potentially malignant or not. But there are a few papers, but until now we haven't got really the pool, more because most of us do not have long follow-up. Okay? And of course, the malignancy, most of you know already, there's not much differences, except that I think it has been recognized before that there is the conventional squamous cell carcinoma with verrucopapillary features, but it's not being sort of given a lot of thought. But this time around, I'm putting it as one of the types, which is conventional squamous cell carcinoma, and I'm going to show a little study which actually shows the differences between the conventional and the actual the conventional squamous cell carcinoma verrucopapillary against the conventional with no verrucopapillary lesions. So let's now talk about malignant lesions, verrucopapillary versus non-verrucopapillary. So the histology of the non-verrucopapillary variants are mainly conventional or SCC without verrucopapillary features, and the other variants are also basaloid squamous cell carcinoma, spindle cell carcinoma, adenosquamous carcinoma, and adenoid squamous cell carcinoma. And these are histology of Verrucopapillary malignancies. So they are conventional because you actually see these papillary features above this normal. However, when you actually look deeper, you actually can see that they are invading here, and then the invasion and all that have all the features, the islands and the pleomorphism, and they have all the features of a conventional squamous cell carcinoma. And similar in this situation, this is the ones without papillary features, and you see this invasion. So those are the two types I'm just trying to put up here. And the histologic differentiation and interpretation of verrucopapillary oral malignancies can be made difficult due to poor orientation, failure to sample the lesional margin, and small specimen size post-primary biopsy. In addition, numerous complex papillary and filiform structures extend in all planes, often making the assessment of true tissue invasion somewhat difficult. So this is a little study that my student, Dr. Shahid, who is, this is part of his study, he's done some molecular, but I'm not going to talk about molecular in this particular lecture. So this is a comparison between the clinical pathologic profiles of verrucopapillary versus non-verrucopapillary oral malignancies. So we looked into our tissue bank, and we were able to get a certain number, but not too big, of cases diagnosed between 2004 and 2016. And we made it into two groups, which is Verrucopapillary lesion group and the non-Verrucopapillary lesion group. And I think I've explained that earlier. And the Verrucopapillary malignancy or non-Verrucopapillary malignancy, which were recurrent, are excluded. Verrucopapillary malignancy or non-Verrucopapillary with incomplete data, because here we would like to have long follow-up data. So we only get 24 cases of verrucopapillary malignancies and 29 cases of non-verrucopapillary malignancy. These are formalin fixed, paraffin embedded tissues, and it's being re-graded or re-looked and confirmed by myself and my colleague, Dr. Thomas George. And this is the result. If you look at verrucopapillary lesion and non-verrucopapillary lesion, they tend to be of older age group, slightly older, and there seem to be more in the Indian population, but there's a lot more to this because I'm sure there are a lot more co-founders there. But in terms of just this direct comparison, and in terms of location, the gingiva and the buccal mucosa is more in the verrucopapillary, whilst the tongue and throat of the mouth is more for the non-verrucopapillary. And when we looked at the depth of invasion, there is a larger depth of invasion in non-verrucopapillary, and looking into neck nodes is a higher percentage of positive neck nodes in the non-verrucopapillary lesion. So you actually can see there is a major difference between malignant verrucopapillary lesion and non-verrucopapillary lesion. So summary results of significance that most of the patients, 70.8% with verrucopapillary oral malignancies were 60 years old and above, while majority of the patients with non-verrucopapillary oral malignancy were less than 60 years old. Most cases of verrucopapillary oral malignancies were located in the buccal mucosa, while most of the non-verrucopapillary oral malignancies were located in tongue and throat of the mouth. So I think I've mentioned just now, if you actually put together buccal mucosa and gingiva, it's actually quite high. And I've also mentioned about depth of invasion. And this is just to show the depth of invasion, that is how we have actually computed it. And 85.7% of non-Verrucopapillary oral malignancies presented with positive lymph nodes, which I've mentioned earlier. And I think most of us know that cervical node metastasis is widely accepted as one of the major prognostic factors in patients with OSCC, and its presence is associated with a decrease in global survival to roughly half, as well as with higher recurrence rate. I think we saw that what Dr. Ranga had shown about the survival. So this reflects that non-Verrucopapillary oral malignancies need to be treated more aggressively than patients with Verrucopapillary oral malignancies. And in our study, all the patients had undergone surgical excision in combination with neck dissection, which was a choice of treatment in non-Verrucopapillary oral malignancies compared to Verrucopapillary oral malignancies. Based on the findings from our study, it may be suggested that neck dissection may be avoided in patients with Verrucopapillary oral malignancies with clinically negative cervical nodes. However, that's only a small sample. We need collaborative effort to pool our cases and confirm these results. So let's move on. In 2013, when I started taking an interest on oral verrucous hyperplasia, it's noted that there is lack of unanimity in terminology and poor recognition of clinical features and histopathologic features. It reflects the lack of well-defined set of diagnostic criteria, and that there's no standardized interpretation of the criteria of verrucous hyperplasia. And these are two verrucous hyperplasia that's considered as sharp variety, blunt variety by in the paper by Shear and Pimbaugh, and another two that is courtesy of Dr. Sunita. There is a little verrucous here, and if you notice, these white lesions, we can actually clinically we can actually call it verrucous leukoplakia. However, this blunt variety will not fit to call it verrucous leukoplakia. Therefore, that's the reason why we came up with a clinical, a new clinical terminology. And this is just to show that histologically, they are all above the surface. And this just goes with the clinical of sharp and here blunted. Okay? So addressing the oral verrucous hyperplasia issues, a consensus workshop to determine an acceptable clinical pathological guideline for recognizing oral verrucous hyperplasia was conducted. And it was the first Asian regional meeting on the terminology and criteria for verrucous papillary lesions of the oral cavity, which was in Kuala Lumpur, Malaysia in December 2013. And at this consensus workshop, participants consist of oral pathologists and oral medicine from the Asian region and Asia Pacific as well. And consensus decision was made on the clinical and pathological criteria of verrucous hyperplasia of the oral cavity. And clinical terminology of verrucous hyperplasia of the oral cavity is then given, which our proposed one was exophytic verrucous hyperplasia to denote the clinical entity that represents a microscopic diagnosis of oral verrucous hyperplasia. However, at that time, we did discuss that the fact that we use verrucous hyperplasia as a clinical entity doesn't sound quite correct, and yet we were not able to come up with any better entity. Therefore, we had this exophytic verrucous hyperplasia. However, I think many pathologists are still arguing that this is probably not suitable because of the word verrucous hyperplasia. And I think I've shown this. So this is the white type, and this is the non-white. You see this papillary, but not sharp. Okay, and this outgrowth clinically, because when you see clinically, we probably don't just say a verrucous hyperplasia. So when you see this clinically as outgrowth, we can call both as exophytic verrucous hyperplasia, although the white lesion can still be called verrucous leukoplakia. So yeah, this is just to say there is the terminology verrucous leukoplakia, which are flat lesions and not exophytic. It's only slightly exophytic by virtue of the little verrucous that is coming above the surface. So it is proposed that exophytic verrucous hyperplasia lesions clinically present in two forms: as an exophytic fleshy verrucopapillary output with a white and or pink surface color, and as a white plug-like exophytic verrucous lesion. The latter may mimic verrucous leukoplakia, and in both instances, we decided that it can be called as exophytic verrucous hyperplasia. And we can describe this verrucous hyperplasia as a single entity, and that's the question. Is this an oral potential malignant disorder? Is it not? And there is no agreement on this yet. Exophytic verrucopapillary features of verrucous hyperplasia has also been observed in oral submucous fibrosis. Therefore, this is part of an oral potential malignant disorder, and it has been included as part of a histological progression of proliferative verrucoplakia and also an OPMD. And I think I missed it. Yeah, this is correct. One is submucous fibrosis, the other one is PVL. So clinical criteria of hyperplasia of oral cavity, as I showed you just now, that one of it is oral submucous fibrosis. But in 2013, when we first discussed this, we already know that it may coexist in a patient presenting with oral submucous fibrosis. And now, by now, there are quite a number of articles. I think the one from Professor Tilak himself, and then there is more, which actually is showing that there is exophytic verrucous hyperplasia in oral submucous fibrosis. The clinical presentation of exophytic verrucous hyperplasia could masquerade as a squamous cell carcinoma or verrucous carcinoma. Absence of induration is a cardinal features of exophytic verrucous hyperplasia. There is a study which has just been published, which is exophytic verrucous hyperplasia in oral submucous fibrosis, where the 662 OSF patients were examined, and they found that 13 patients presented with solitary verrucopapillary lesions in an OSF background. So oral verrucous hyperplasia and EVH with justification also proposes to introduce new terminologies such as oral verrucous dysplasia and exophytic verrucous dysplasia. So I didn't put it here, but just a little bit of explanation. They actually do, if I'm not mistaken, they actually use a well scope to look into the possibility of it having dysplasia. And after discussing this issue, they felt that there is the flat variety which actually can be called oral verrucous. I think there is a flat variety which can be called oral verrucous hyperplasia, and there is the other variety which is called exophytic verrucous hyperplasia. But in their cases, all their cases of OSF do not have dysplasia. So they actually proposed that there will be another two definitions of two names, which is oral verrucous dysplasia for the flat lesions and exophytic verrucous dysplasia. So these are new things that people have suggested, which actually means that we need to get together, get more cases and discuss this, because we need to see what all this will become and how it will affect the treatment and management of patients. So histopathological criteria of verrucous hyperplasia of the oral cavity, the following criteria was accepted during our 2013 workshop, which is keratinized exophytic verrucopapillary process where there is pantene plugging. Epithelium is hypoplastic with both basal cell hyperplasia and acanthosis. And there is absence of downward growth. Here we bold it, but downward growth is meant for verrucous carcinoma into lamina propria as compared with the level of basement membrane. And epithelial dysplasia may or may not be present. So that was at that time our criteria. And as I said, there is a suggestion to split this as well. And there is subepithelial lymphocytic infiltration as a host response, may or may not be present. And verrucous hyperplasia should be clearly differentiated from verrucous carcinoma, which exhibits frank downward growth of the epithelial processes below the level of the basement membrane of the adjacent normal epithelium. So what we're saying is verrucous hyperplasia do not have downward growth or frank downward growth, whereas the verrucous carcinoma will have downward growth, and the squamous cell carcinoma with papillary features would have invasion. So this is something that we had worked out and published it, where we actually put down all the possible criteria for histological diagnosis. And this is the diagnosis: oral verrucous carcinoma, papillary squamous cell carcinoma, conventional squamous cell carcinoma, oral verrucous hyperplasia, and squamous cell papilloma. And these are the criteria that we put in, and these were the criteria that we used when we were doing that project that I have explained earlier. And in this study, we had a report on that, and based on this report, Patel et al. Uses it and actually could classify 37.3% into oral verrucous hyperplasia with dysplastic features in 68.5%. And we've had another publication that will give you a guide of how to go about diagnosing exophytic verrucous hyperplasia and how to differentiate it from verrucous carcinoma, conventional squamous cell carcinoma, papillary squamous cell carcinoma. So now I would like to speak a little bit more about proliferative verrucous leukoplakia, where I mentioned earlier that there is a verrucous hyperplasia. So this has been accepted as a potentially malignant disorder, and this is mentioned in the WHO 2017. And this is a distinct and aggressive form of oral potentially malignant disorder, simultaneous leukoplakias at multiple sites occurring at different times, progressive with high recurrence and malignant transformation rates, 70% or more develop invasive cancer. And the WHO 2017 mentioned that for 4 clinical stages, there is focal flat white keratosis, diffuse multifocal white patches, slowly progressive horizontal and exophytic, resulting in warty surface with focal erythematous areas, development of verrucous carcinoma or squamous cell carcinoma. And this is actually a paper that was done in 2003, where we were trying to put this into proliferative verrucous leukoplakia, but we were not able to because we did not see the patient from the start. The patient comes with a cancer, and then later the patient comes with a flat lesion, and then the cancer was removed, and then there is recurrence, and there is also lesions in other areas. So this is the beginning where we started questioning, could we call this proliferative verrucous leukoplakia or is it not? So this, I'm introducing this back because it has a bearing to another suggestion in a more current paper. So the histopathology in the WHO 2017 says localized flat or verrucous hyperorthokeratosis. So that would be the usual benign leukoplakia, local flat if there is minimal dysplasia, or the usual display oral epithelial dysplasia if it is localized flat. But when it is verrucous hyperplasia, whether it's orthokeratosis or not, we look into minimal or no dysplasia. Yeah? And progression into advanced stage of atypical verrucous hyperplasia. So the flat ones, or even if we had seen the verrucous type earlier, it would progress into the advanced stage of verrucous, a full-blown verrucous hyperplasia, and dysplasia during late stages. And this would also progress into verrucous carcinoma and conventional squamous cell carcinoma. You frequently see interface mucositis, which is a band-like lymphocytic infiltrate subjacent to the basal cell layer. So basically, proliferative verrucous leukoplakia can be a little confusing in how do we really diagnose that? Are we sure that we are diagnosing proliferative verrucous leukoplakia? I think in a place where patients come in early and they are being followed up. There is no loss to follow up. This is well and good. But I think in our region, most of the time, when the lesions are early, we do not see them. And yet, when they come late, we're saying to ourselves, is this proliferative verrucous leukoplakia? And it is quite important to recognize because of its malignant potential. So from WHO, here just showing the clinical lesion, and it can be flat, a histological lesion, or it can be a verrucous histological lesion. And the histology would be focal flat keratosis, diffuse multifocal white patches, slowly progressive horizontal and exophytic growth, and it can develop into verrucous carcinoma or oral squamous cell carcinoma. So verrucous hyperplasia or verrucous keratosis is a known, challenging, and difficult diagnosis. There is very little agreement between pathologists, and it's very ambiguous in interpretation by the oral maxillofacial surgeon. Okay, and this is a more recent study by Jasbir et al., where they have a number of pathologists look into inter-observer variability in diagnosis of proliferative verrucous leukoplakia, and it is very difficult. And they find that the most difficult part is the verrucous hyperplasia, the diagnosis of verrucous hyperplasia. And then they actually also look into the implications to oral maxillofacial surgeon. And oral maxillofacial surgeon is plagued by a number of diagnoses, verrucous hyperplasia, verrucous keratosis, and things like that. And the oral maxillofacial surgeons are not sure which way they are supposed to do. Okay, of course, like we tend to say, you should be discussing with us, but the point is we are also, as pathologists, not sure what way verrucous hyperplasia is going towards. Will the ones with no dysplasia change to cancer, or will the one with dysplasia change to cancer, or both, or not? So these are questions that need to ask, and we still have no answer. And since 2013, when we developed that criteria, we still do not have many cases that has been published that we can look at the long-term follow-up data. And it has been shown that, especially in the early initial stages, all proliferative verrucoplakia do not have a verrucoid appearance. And it's also been recently described as a clinical diagnosis of proliferative verrucous leukoplakia to patients presenting with multifocal lesions that are devoid of verrucous appearance. So there are also now suggestions, okay, on the basis of involvement of multiple sites. There is a suggestion that without the verrucous appearance, with only multifocal white lesions, that this be termed proliferative multifocal leukoplakia and can be taken as a proliferative verrucous leukoplakia, which is probably at an early stage and therefore will actually be a kind of early diagnosis, right? And yet, I think we still need to do a lot of study on this, put our cases together, and actually see what will happen. Because I'm not saying we will accept this, I'm saying that this is the suggestion, and whether in our region, okay, this suggestion could be taken because we do not see the patient early, and then but when they come, we may see the cancer. But if they come at a stage where we actually see multiple flat lesions, could we not say this is potentially proliferative verrucous leukoplakia? So our areas of concern for proliferative verrucous leukoplakia is poor reproducibility between pathologists. This was in the collaborative study that I've mentioned. Need to be able to reliably recognize proliferative verrucous leukoplakia. Therefore, it's critical because of the high potential for malignant transformation and follow-up, and problems in interpretation of the varied diagnosis by oral maxillofacial surgeon. And this is it has implication on the treatment. And we also need to prevent PVL progression but we can't prevent if we cannot detect it early. Therefore, the need to look at the PVL criteria as applied to different regions. And we're talking about our region, the Asian region. Therefore, we need a large number of cases, large patient pool, and do we need to recognize these multifocal lesions that are devoid of verrucous appearance? Yeah, and therefore we really need. I feel that we really need another conference, another workshop on this to look back on what we have, the criteria that we have, and to see whether we need to change, we need to remove it, or we need to keep it and add other terminologies. And this is just things that I've done that I wanted to share with you. For example, this is a patient that we get, this is probably clinically a flat lesion, apical dysplasia, but it had developed further, whereas this area, it is actually a verrucous hyperplasia, and we could actually see that it becomes, that is the verrucous carcinoma. And then we followed it up, further have it removed, things like that. And this was followed for quite a number of years. So this is from 2010. And the last time I had this is 2016. So this is the kind of thing that we would like us to get together and put and get our patients, have follow up and actually record them, whichever way. I'm just showing one of the way that I've done, but this was done retrospectively. It's not done prospectively. Okay, it was done by looking back at the patient files and putting pieces together. Okay? And this is just to show the patient where we have this Verrucopapillary lesion, and we also have this leukoplakia here, and here it has enlarged. Okay? So I'm almost done. So concerns. There are many more issues after 2013 meeting as developed criteria are being used. We need standard criteria accepted for the Asian region. Progression of these cases in Asia may now be studied prospectively, or while wanting to develop something prospectively, we can still look into things retrospectively. We need to relook into exophytic verrucous hyperplasia, whether we want to increase, whether we want to have other terminologies, whether we want to modify these terminologies, because I think every time that this terminology is being put up to pathologies in general, I think the main issue is that there is nothing that actually show, we were unable to show that this, if it is independently, these are the ones that become cancer. So we're not sure that it is OPMD. Okay, so need to relook into verrucous hyperplasia in OSF, and I think that you have many in India, and I'm sure people are already studying that, but definitely it's worth getting together, looking into what are the things we want to look into. Need to relook into verrucous hyperplasia in proliferative verrucous leukoplakia, and need to look into how do we do early detection of proliferative verrucous leukoplakia. Should we recognize proliferative multiple leukoplakia, or is there other ways to, other criteria that we can recognize? So I would like to conclude by saying I would like to call for a revival of the Asian Consortium of Verrucopapillary lesion, which we started in 2016, I think in 2013 more so, and in 2016 we had another meeting, but it's not the whole meeting. And can we put this as an activity under ASOMP? So with that, thank you.